This presentation is made on behalf of Boehringer Ingelheim Pharmaceuticals, Inc. The company has provided financial support for this program. Presentation content has been reviewed for consistency with FDA guidelines.
Hi, my name is Rob Su. Today we're going to cover UIP on HRCT. So let me take you through a normal just to refresh your memory. And here we have a inspiratory 1 millimeter cuts. And I'm going to just scroll through this so that we can appreciate what normal CT looks like in normal lungs. One of the things that we'll talk about is the difference between central and peripheral. And by central and peripheral, we're really talking about not so much the location in the chest, but what's happening with the locations within the lung. And so, for example, if we look at the CT that I have up right now, we have the right upper lobe, and central is really this core area that's fed by the large arteries, bronchi, and drained by the large veins. And when we talk about peripheral, we're really talking about the outer 1 to 2 centimeters of the lobe here. And you can see as I'm outlining what that might look like. And when we talk about central, it's all of the rest of the lobe here, including the more central portions that include the large bronchi and blood vessels. And it's not so much peripheral like out at the outer edge of the chest versus center next to the heart. And to some degree, you may even have what we call peripheral lung in the center of the chest. And so this, again, just to take you through normal, this is really what you should appreciate is kind of the nice manner which the blood vessels and the airways branch. And notice the attenuation or the density of the lungs. Again, they're fairly black with the exception of these small blood vessels and airways throughout. All right, now, as we talked about also, when we talk about interstitial lung diseases, we'll talk about central versus peripheral within the lobe and the lung itself. And then we'll also talk about distribution of the disease, whether it's upper lung, lower lung. And when we look at distribution of the disease, especially with diffuse processes or infiltrated processes of the lung, it's really nice to look at the coronal reformats. And so again, I'll just take you through what a normal coronal looks like so you can appreciate that. And here we see the right upper lobe, the right middle lobe, and we have some of the right lower lobe as we go into the back of the mid portion and the back of the chest. Here we have the left upper lobe and the left lower lobe here. And again, this is a normal CT. Again, you can see very nicely that the lung density is pretty dark, as on the axial images, with the exception of blood vessels, and we see the small airways or these ring-like structures. This is the spine just for reference. And we're just kind of coming back out. This is the trachea branching into the right and left mainstem bronchi. And as we come anteriorly, we can see the manubrium and the sternum. So here we have axial 1 millimeter images from a high resolution CT on this patient. So as we go from the top to the bottom of the chest, we'll take you through some of the features. And notice that here we're going to just stop for a moment here and look at the lung apices. First of all, you can see that the density of the lung is not normal, or it looks grayer than what we saw on the normal CT. The other thing is that we see what we call reticulations. And so these are these little lines that are at the edges, and I'll show you more of those as we go further down into the chest. And what you also notice is that there's the surfaces where the lung touches the pleura are very irregular and almost serrated. And you can see that here. There's not a very nice smooth interface. Now, as we go a little bit farther down, we see that the lung looks very much more abnormal. And we see that not only are the reticulations in these areas. The interface is, again, looking very abnormal at the pleural parenchymal contact. And we see these collections of air cysts, and these are what we call, or what are known as, honeycombs. And so this is destruction of the typical alveolar architecture by exuberant fibrous formation, leaving these irregular cysts. And again, it's very important that when you look at these cysts or look for honeycombs, you're really looking for an air-like density. So for reference, this is the right interlobar bronchus, and you can see that the air density is quite dark, and in fact darker than lung, because there's just air within the airway. And the honeycomb spaces should be this dark, because if you see gray inside or in the middle of these areas, such as this is more reticulation and abnormal lung, but not a true honeycomb as I'm pointing out here. And we can see that that's quite a bit of honeycombing as we go down farther. Now notice that when we look at where the abnormality is, the reticulation, the honeycombing, it's out at the very periphery of the lung, but we can see that, again, we can see that most of the disease is around the edges of the lung. And as we go to where there's less involvement, we can see that, again, the center portions, even though they're abnormal, they're not quite as diseased as in the periphery of the lobes. Now, let me show you here. So we're here in the middle lobe, and here we have the lateral segmental bronchus of the middle lobe. And if we follow this out, we can see that normal bronchi should taper as we go to the periphery, but you can see how irregular and varicoid this bronchus is and this bronchiole is. And this is what's known as traction bronchiectasis and bronchiolectasis. And when you see this, especially if you look immediately outside of that abnormal airway and you see abnormal lung, you should put two and two together and think of traction as cause for why this airway is dilated. And again, you can see that. And look at how abnormal these airways are, right? And so there's a very nice example of traction bronchiectasis and bronchiolectasis. Now, let's just go further down, and we're going to be here at, just to orient you, we're at the level of the diaphragm. Here's the right hemidiaphragm. And we can see at this point, the lobes, because we're kind of at the periphery or the basilar periphery of the lobes of the middle lobe and the lower lobe, you can see that there's extensive disease throughout, because essentially we're at the bottom edge of the lung. And here we can see reticulation, but we also see a lot of honeycombing. And on the left, although the heart here is pushing the lung on the lung, and we don't see as much of the left lower lobe and lingula, we can again see reticulation, honeycombing, and some traction bronchiectasis and bronchiolectasis. So the hallmark of UIP on HRCT is to identify honeycombing or the presence of honeycombs. And then to some degree, you'll certainly have reticulations and traction bronchiectasis and bronchiolectasis. Now, this distribution should be, again, within the basilar periphery of the lung, or favor the basilar periphery of the lung. So let's look at, on a coronal reformat, how easy this is to see. So I'm going to just scroll kind of to the middle portion of the chest, to the back. And so we're just at the thoracic spine here. And we can see that certainly the lung from the apex down to the bases looks abnormal. But notice that that abnormality is much more extensive as we head to the bases. Now, again, you don't have to recognize what this is, but if I just told you, point to where the lung is the most abnormal, I think most people would point to down at the bases here. And if I go a little bit further back, so we're heading to the posterior periphery, or the edge of the lung, and we see more of the spine here, we can see that, first of all, there's more abnormality as we get down to the bases, but notice that most of this disease is, again, out at the periphery or in the back. And if we go look a little bit more anteriorly, you can see that again, it's a very peripheral process. So with UIP, you want to first recognize honeycombing. There will be some degree of reticulation and traction bronchiectasis and bronchiectasis, and the distribution of these abnormalities should favor the lung periphery and at the bases. All right, so let's look at another case of UIP. Again, just to reiterate, we want to see honeycombing first and foremost. We will see some reticulation, and we'll see some traction bronchiectasis and bronchiectasis. The distribution of these abnormalities should be out in the periphery of the lobes or the lung and favor the lung bases. So let's go ahead and take a look. I'm going to just scroll down, and to orient you, we're here at the apex or at the apices of both lungs. And right off the bat, we can see that whatever abnormality we see seems to favor the periphery of the lobes. And again, we can see that here. And by periphery, again, just to reiterate, we're talking about the outer 1 to 2 centimeters of the lobe. Here we can, right off the bat, see honeycombing. And we see these abnormal cysts that range in size anywhere between 3 and 10 millimeters, but can be larger. And most importantly, we see that the center of these cysts is air density approximating that of even the air within the trachea in this case. And when you see this, this is really consistent with honeycombing, especially if there are multiple and sharing these irregular thickened walls. And you can certainly make the diagnosis when the honeycombing is stacked or layered on one another. But even today on thin section HRCT, because we can follow abnormal airways down to the periphery, we can decipher or distinguish what's traction bronchiectasis and bronchiectasis versus true honeycombing. So even a monolayer of honeycombing can be confidently diagnosed. So I'm going to scroll a little bit more forward or more into the chest. And just to orient you, we're here at the level of the bifurcation of the trachea. We see the right mainstem bronchus and the left mainstem bronchus. And again, we see that the abnormality is confined to the edges or the periphery of the lobes that we're seeing. We see reticulation, which are these lines or hash marks. We see honeycombing, and we do see some elements of traction bronchiectasis and bronchiectasis. Now, let's go a little bit further, more inferiorly, and I'll show you, just point out a nice case, example of traction bronchiectasis. So here we're in the upper lobe anterior segment, and we can, if we follow this airway, we can see just how irregular it is as we go out to the periphery. And we can see that it abnormally dilates when a normal airway should certainly taper as we get out to the periphery. If we look immediately outside of the airway, we can see that the lung is highly abnormal. So when we put two and two together, we should be thinking about traction changes of the airways, or traction bronchiectasis and bronchiectasis. Another clue is that despite how abnormal this airway is, it's not particularly thickened. And so that steers us again away from an airway intrinsic cause of the airway dilation. We can see some very nice honeycombs, and some of these, we also see some cystic changes within the lung itself as well. So let's go a little bit further down, and now we're at the level of the middle lobe, the right middle lobe and the right lower lobe, the lingula and the left lower lobe. Again, we see some nice traction bronchiectasis and bronchiectasis bilaterally. We see, again, a lot of honeycombing, and notice it's out in the periphery of the lobes, or it favors the periphery of the lobe. And again, if we look here, this is central in the chest, and just as I mentioned earlier, central in the chest doesn't necessarily mean peripheral. We're really, when we talk about central and peripheral, it's relative to the lobe. And so even though this area is central to the chest, it's really peripheral to the lobe. All right, so let's go a little bit farther down, and we're going to just take it to just the top of the left hemidiaphragm. And so here we're very much very close to the lung bases, And we can see on the right, or the right lower lobe, has extensive peripheral honeycombing. We have also some areas of reticulation. And as I showed you, some nice examples of traction bronchiectasis and bronchiolectasis. On the left, we can see that almost the entire lung is now diseased, or we see a lot of honeycombing throughout admixed with reticulation. By here, since we're seeing the diaphragm, we're really at the edge of the lower lobe and the lingula. And finally, if we go down all the way to the bottom here, so we're seeing now the right hemidiaphragm and the liver underneath, we can see that there's, again, extensive honeycombing admixed with some areas of reticulation. And notice here, again, some might think that this area is honeycombing, but notice that there's a little bit of gray in there. And so this isn't really true honeycombing as of yet, but you can see quite a bit of honeycombing elsewhere throughout. Let's move on to the coronal images that go with this case. Again, this will help us really nail down the distribution of disease. And as I scroll from anterior to posterior, we can, let me just find a nice example here to stop. We can see that the disease is clearly peripheral, and it has a basilar distribution. And as we get to the posterior lung bases, and again, this is the spine for reference, we see that there's a lot more of this honeycombing, not only in the periphery of the lung, but favoring the lung bases as well. And here anteriorly, we can see again peripheral and basilar predominance of the abnormality. So there you have it. Here, we've looked at 2 cases of UIP. So remember, first and foremost, we'd like to see honeycombing that's basilar and peripheral in distribution. If you see honeycombing, then pretty much you've made that radiographic diagnosis of UIP. We'll also see reticulation and traction bronchiectasis and bronchiolectasis. And remember, the distribution of these abnormalities should be basilar and peripheral. Thank you for watching.